fractional flow reserve, or FFR, that is used to determine if a stenosis is what's causing ischemia. So a patient comes in, they're having chest pain. Let's say we do an angiogram, we see a mild to moderate stenosis. Should we fix it or not? Well, is that what's causing the chest pain? Well, we could do FFR to find that out. So if it is determined that it is causing the ischemia or chest pain or problems, then we can put in a stent or do an intervention. But if the FFR determines that it's not causing problems, it's not causing the ischemia, not causing damage to the heart, then we save the patient from an unnecessary procedure. So as FFR is concerned, all normal arteries are 1.0. So that's all normal arteries are 1.0. So less than 0.75 confirms a significant stenosis, so it needs to be fixed. If it's above 0.75, then usually it's deemed that it's not causing significant problems, and so just leave the lesion alone. So the actual procedure, it is a guide wire that has a transducer on the tip of it. The actual procedure, the wire must be zeroed. Then the wire is advanced into the guide catheter where it has to be normalized to match the guide catheter pressure. The tip of the wire, again, that has the transducer now must cross the lesion. And at this point, a lot of times the pressures are the same on both sides of the lesion, but not always. But really that doesn't matter. As long as the wire is zeroed and the pressures are normalized before you cross the lesion, that's what's most important. Then after you cross the lesion, the pressures might be a little bit different. That's okay. At that point, then a hyperemic agent is injected, usually adenosine, and what that is a drug that increases blood flow, and what that does is it simulates the increase of blood flow that occurs during exercise, because that's when a lot of times people say they have their chest pain is during exercise. So you're trying to duplicate that occurrence of the chest pain during exercise. So instead of actually having the patient exercise, we give them the adenosine, which simulates that. Okay, so so the wire is across the lesion. We have given the adenosine or the hyperemic agent. So now is when we need to capture the FFR. So again, if it's less than 0.75, then we need to fix it. If it's above 0.75, then it does not need fixed. So here is an example, and here's the actual calculation. Distal pressure divided by arterial pressure equals the FFR. So here is a typical screen, what it looks like. And so again, so here is at the resting state. So once the wire crossed the lesion, there already was a gradient, because this is the regular arterial pressure, and then this is distal to the lesion pressure. So even without the adenosine, there was a gradient. But then once the adenosine was introduced, as you can see, and that's usually introduced either IV or intracoronary. But then once the adenosine was introduced, then the pressure gradient became much bigger. And so the regular arterial pressure was 80 and the distal pressure was 47. And so if you take 47 divided by 80, which is the formula here, then you get 0.58, which is clearly less than 0.75. So this is a lesion that does need fixed. And there's also a video that they show this procedure being done in the cath lab. It's pretty good. I'm going to share a link to that as well.